Alright guys, well here we are. We're going to talk about the reproductive system. Well, I plan to take the approach of doing this in multiple parts, maybe 3 parts. The first part we're going to introduce the general aspects of the reproductive system, and we'll then get into the male reproductive system, and then about halfway through the male reproductive system we'll introduce a special type of sex cell division called meiosis, and we'll go over that. And then we'll get into the female reproductive system, and then we'll talk a little bit about the sex hormones that are involved in the ovarian cycle in the female. The female reproductive system, not surprisingly, is quite a bit more complex than the male, because the female system has to have the organs that are capable of sustaining the developing embryo and fetus. So, in short, the reproductive system is pretty simple. The idea is that we have these supportive structures that generate what are called the sex cells, and sex cells are known as gametes. That's the term for both male and female sex cells. The male sex cell is a spermatozoa, or sperm, and the female sex cell is the ovum, or ova. You would know the ova as an egg. And these are very special cells. Every cell in our body, except these, has 46 chromosomes, 2 sets of 23. Every cell in our body that has that complement of chromosomes is called a somatic cell. And all somatic cells are derived from one another by a process called mitosis, where one parent cell divides and gives rise to 2 genetically identical daughter cells. The reason I say all the cells in your body except these are derived that way, because these cells, the sex cells, are derived by a special type of cell division called meiosis, and among other things, meiosis divides the chromosome number from 46 to 23. And it does so precisely such that we get one member of each what we call homologous set of chromosomes. So our chromosomes are paired up into 2 sets of 23. So we take one of those sets of 23, but not one whole set from mom or one whole set from dad, but we select one pair in a very organized process. So the production of these gametes is called gametogenesis, and we'll spend some time talking about gametogenesis. Gametogenesis occurs in the primary sex organs, which are the gonads, and that's a real term, even though it's one that's been around and been used by kids to make fun of other people and just to snicker at for years, but it's a real correct term. So male gonads are testes, and the female gonads are ovaries. The male testes are actually located outside the main abdominal cavity, whereas the ovaries are nestled snugly deep inside the female's pelvic cavity, near the border between the pelvic cavity and the abdominal cavity. In addition to the main sex organs, the gonads, we have reproductive ductwork and the external genitalia, which are the copulatory organs. So I mentioned that the hormones are going to play a role in sexual development and libido. Well, the hormones that we have here, the previous slide mentioned them. In males, they're called androgens, and the main androgen is testosterone. In females, we have a group of related compounds called estrogens, and a similar compound called progesterone. What these have in common in males and females is that they drive the process of gametogenesis, and they themselves are prompted to be produced in the primary sex organs by pituitary hormones FSH and LH. So we'll talk about that regulatory role of these hormones a little bit later. These hormones also drive the development of the familiar secondary sexual characteristics that we associate with maleness and femaleness. Things like larger amount of bone mass and muscle mass and hair in males than in females. Females slightly more adipose tissue than males. Breast development, pubic hair development, and pheromones. The hormones also play a role in the libido, or the sex drive. So let's start with some of the male reproductive details. So we mentioned that the male gonad is the testes located within the scrotum. and we'll show a picture of that in just a second here. And then the ductwork that delivers the sperm that are developed in the testes to the copulatory organs is listed below here, and we'll go over that on the diagram. In addition to the testes and the ductwork and the copulatory organs, the males also have three main accessory glands, and they're called the seminal vesicles, or here the seminal glands, the prostate, and the bulbourethral glands. These all contribute to the seminal fluid, well, not to the seminal fluid, but to the semen. In fact, you might be surprised to learn that of the ejaculate volume that a male has, which is somewhere in the neighborhood of 4 to 6 mils per ejaculate in that area somewhere, that most of that fluid is not sperm-containing fluid. Maybe half a mil of that is sperm-containing fluid. Most of it is seminal fluid produced by the seminal vesicles, and it's nourishment and pH buffering for the sperm. So we'll talk about the contributions that the seminal glands and the prostate and the bulbourethral glands have to the ejaculate and to the conditioning and protection and nourishment of the sperm. So here's a sagittal section of the male reproductive tract showing essentially the male pelvis from the lateral aspect. And this looks very much like one of the 3D relief boards that we have in lab, and you've probably started learning these structures already. I think just about everything on this list is something that you're expected to know. So if we were to start in kind of the obvious place here with the location of the testes. So the testes are located in the scrotal sac. So there's the scrotal sac. And that's just an extension of this of the integument, which forms this folded sac, and inside of that we have a layer of muscular tissue interlaced with some fibrous tissue, and that's called the dartos muscle. And the dartos muscle, when it contracts, can actually flatten the testes up against the body wall to conserve heat. And you go underneath that, and we get two thin serous membranes called the tunica vaginalis, both parietal and visceral layers. And those are extensions of the parietal peritoneum from the abdominal cavity. And then if we go underneath that, what we would find is the testis itself, and that is this white structure right here. It's white because it's covered with a dense, regular CT layer called the tunica albuginea. And albuginea just lends its name to the fact that it's white. We cross-section through this and we'll see several internal septa, dividing this up into multiple compartments, with literally hundreds of meters of tiny little microscopic tubules called seminiferous tubules. So the testis, while it looks like an egg, if you cut it open, it has a highly divided or septate nature, and in there it looks like coiled ramen noodles, and those coiled noodles are the seminiferous tubules. Within the seminiferous tubules, that is where sperm production takes place. So the seminiferous tubules in the male are the site within the testes where sperm production takes place. And we remember that sperm production is an example of gametogenesis. Now, interestingly, the sperm that are formed in the testis are immature, and they're called spermatids. They have to travel, or actually be conducted, via some ductules into this structure, which is the epididymis. So this kind of pink horn-shaped structure all the way here, that's the epididymis. And the epididymis consists of a head here, and a body, and a tail. Head, body, tail. The spermatids are conducted via efferent ductules into the head of the epididymis, and then they're going to mature for another 40 days as they travel from the head, progressively tumbling through these tubes in the epididymis down to the tail of the epididymis. It is in the tail of the epididymis that the sperm actually are mature they're called capacitated in the tail of the epididymis. If you were to extract spermatozoa from the tail of the epididymis, you could actually fertilize an egg in vitro with them. Whereas if you were to take sperm from the head of the epididymis, they would not be able to fertilize an egg. Even though they have all the right genetic material, there's a special enzyme-filled cap on the front of a spermatozoon called the acrosome, and there has to be a special acrosomal reaction with the egg cell membrane in order for the two to fuse. And it's not until the sperm become capacitated that that acrosomal reaction becomes activated, or is at least possibly activated. Okay, so the spermatids make their way to the epididymis, where they travel through the epididymis while they mature. And then ultimately the goal here is to take these spermatozoa through a section of tubules up to what is called the ejaculatory duct, right at the base of the prostate, and then from the ejaculatory duct through the urethra and out for ejaculation. And if we're trying to create a baby here, that would obviously be ejaculated into the female reproductive tract. So how do we get all the way there? Well, it's a series of tubules and glands. The largest tubule is this one right here. It runs from the posterior of the testes up through the anterior body wall of the pubis, of the pelvic cavity, and over top of the pubis, laterally along the urinary bladder, squeezing between the ureter, coming from the kidneys, and coursing along the posterior of the bladder, and then until it gets to the base of the bladder where it joins what's called the ejaculatory duct. So this structure right here is the ejaculatory duct, which really is just the last part of the vas deferens. So the ductus deferens is that tube that connects the testes to the ejaculatory duct. So it's either called the ductus deferens or the vas deferens, slightly older term. The process of moving the sperm from the epididymis to the ejaculatory duct is actually not ejaculation. That's called emission. Emission is the movement of sperm from the tail of the epididymis to the ejaculatory duct, and that occurs just prior to ejaculation. Ejaculation in the male is the spasmodic contraction of the urogenital diaphragm musculature, compressing the base of the penis, which is where the ejaculatory duct is housed. And when we compress that, then the ejaculate volume is expelled out through the urethra. So that material has to be moved up pre-ejaculation to the ejaculatory duct and stored there briefly. We'll talk a little bit about the nervous system stimulation that's required to achieve emission and ejaculation a little bit later. So when the semen or the sperm get up to the ejaculatory duct, well, there's this funny looking gland right here, which looks a little bit like a wasp nest, I guess. It's kind of fatty tissue. And that gland is called the seminal vesicle. And really, as the vas deferens passes next to the seminal vesicle, it kind of enlarges and functions like the seminal vesicle at the same point. The seminal vesicle contributes its seminal fluid to the ejaculatory volume, and really most of the ejaculate is seminal fluid. The main function of seminal fluid is to provide fructose, a carbohydrate source for the sperm, so they remain nourished while they are in the female reproductive tract. Then you'll notice that the ejaculatory duct itself is buried within the body of this larger, shown here in kind of yellow, structure. That structure, which is usually described as walnut-shaped, is the prostate. And the prostate is a fibromuscular gland that contributes about 20% to the ejaculate volume of what's called prostatic fluid. Prostatic fluid's main function is to provide some weak clotting factors and some cytokines, chiefly prostaglandins, that'll stimulate smooth muscle contraction, and it's thought that that aids in the motility of the sperm in the female reproductive tract. And lastly, there's one tiny little gland down here called the Cowper's gland, C-O-W-P-E-R''S, or the newer term is the bulbourethral gland. And it's not connected to the ejaculatory duct. It's actually connected to the urethra. So the ejaculatory duct extends down here where it meets the urethra, and the urethra conducts urine from the urinary bladder down into the penis. So at ejaculation, we've got the semen here that's arrived in the ejaculatory duct due to emission, and then the first thing that happens just as ejaculation begins is Cowper's fluid, bulbourethral fluid, is secreted, and bulbourethral fluid contains mucus and some bicarbonate and some other alkaline secretions that help neutralize any acidic material that may still be in the urethra. And so that's actually released just prior to the ejaculatory duct emptying to kind of precondition the urethra so that as the sperm pass through, they're not harmed. This would be called pre-ejaculate, the material it's a very thin, kind of opaque fluid. That's the pre-ejaculate volume. Then the seminal fluid containing the sperm and the prostatic fluid and the seminal fluid, so that's all semen, is then released during ejaculation. And we pass through the regions of the urethra. So let's clean up our diagram a little bit here so we can see what we're looking at. The regions of the urethra are threefold. The part that passes through the prostate is not surprisingly called the prostatic urethra. And then just this area right here, where it passes through the urogenital diaphragm, and that's just a catch-all term for the muscles that are attached to the pubis and the ischium and the sacrum in this area here. At that point, it becomes the membranous urethra, which has a system of fine channels that pass through that musculature. And then we go into the penis, which is this light blue material here. And from that point on, it's called the spongy urethra. So all of this is called the spongy urethra. It's called a spongy urethra because it's surrounded by an erectile tissue here called the corpora spongiosum. And when blood backs up into this area, we call that engorgement, and that helps make the penis erect for copulation. But the corpora spongiosum's main job is actually to puff up like a cuff and surround the urethra and keep it open, so that when ejaculation occurs, the fluid has a pathway to get out. Otherwise, it would just collapse with the engorgement of the tissue around here. The corpora spongiosum is on the ventral surface of the penis, and on the posterior surface of the penis is the corpora cavernosa. And there are actually two of these structures that are both a little bit on the lateral sides of the penis, and then the corpora spongiosum is on the underneath. And the corpora cavernosum, those are actually the two main erectile tissues. When they become engorged with blood, they are what make the penis become erect for copulation. The penis ends in what's called the glans penis, or the head, and that is covered by what's called the prepuce. The prepuce is a fold of skin, which we would call the foreskin. And that's what is typically removed if somebody is circumcised. They just cut this flap of skin back to this area here. Okay. And I think in brief, that covers most of the structures that we need to know from this diagram. So why the testes hangs outside the body? Good question. As any guy will tell you, it's not convenient. It's one of the more unpleasant things to have that area get hit. The advantage to the male seems to be that by having it in the scrotal sac, that we lower the body temperature, and gametogenesis is simply more efficient at a lower temperature. So on average about 3 degrees Celsius lower than core body temperature. And that can be adjusted. There are two muscles that help adjust the position of the testes. I mentioned one already called the dartos muscle, which is that superficial fibromuscular layer that flattens the testes up against the body wall when it becomes cold. And then another one is a cord that hangs down in what's called the spermatocord, and that can actually elevate the testes and pull them sort of actually almost up inside the body cavity. And that muscle is called the cremaster muscle. And I'll show you the spermatocord picture in a little bit, and I'll point out the cremaster muscle at that time. And then likewise, when it's too warm, both of those muscles will relax and let the testes fall away from the body wall where they can cool down. Here are the two muscles I was referring to. This layer right here that's been cut through is, where is it? Right here. Okay. This is the dartos muscle here. That's the one that when it contracts, it just kind of flattens the testes up against the back body wall. Right? And then deeper to that is this structure, and that is the cremaster muscle. And when this one contracts, it actually elevates the testes back up here. And those two together can work to elevate the testes and flatten them up against the body wall, again, as a way to warm them back up. And when they relax, and the testes are dropped lower away from the body for cooling. Well, we're looking at an anterior picture, and what we're seeing here is the scrotal sac has been reflected open to show us the connective tissue layers. So there's the skin of the integument, dartos muscle. Then we get what's called a fascia that covers the spermatocord. Now this structure coming down here through the inguinal canal, right there, passing down this way, this whole thing, is the spermatocord. And the spermatocord is a multifaceted organ. And it has a fascia sheath, connective tissue sheath on the outside, and you cut underneath that, and you get these fibers of the cremaster muscle here. And if you cut that open, well, then you'll see a network of blood vessels in there. The blue are veins, and these are actually the testicular veins, but they're in a network, and so they get called the pampiniform plexus. This word right here, or set of words. The pampiniform plexus is just a highly sprawled collection of veins that are bringing blood down into the testis. They're spread out like that to function as a radiator. As the blood flows up from the testes, I think I said down, I'm sorry. As the blood flows up from the testes back into the body, heat is given up. It can be given up to the internal environment, or more than likely, heat is absorbed from the incoming testicular artery, which is a little deeper. It's the red artery there. So as warm blood comes down, we can shed that heat into the pampiniform plexus as it goes back up, and it functions as a heat exchanger. So we minimize the heat loss in the testes. And obviously, if we dilate that structure, then we can flood more heat down into here. So it's a way of regulating the temperature of the testes as well, but mainly the pampiniform plexus functions as a heat absorber to minimize heat loss in the testes. Also in the spermatocord, we have some nerve fibers of the autonomic nervous system, and we have the vas deferens, which really can't be seen here because it's kind of occluded by the blood vessels, but there it is on the edge. And as we come up there, now it becomes clear. There's the vas deferens right there. All right. So within our spermatocord, we've got a fascia that covers it. And inside there, we have the pampiniform plexus, which are the testicular veins. We have the testicular artery, autonomic nerve fibers, and the ductus deferens. And that, again, makes up our spermatocord. And so that comes down and then closes the testes. And we know that then the vas deferens would connect in the back here to the tail of the epididymis, and there's the head of the epididymis. So let's take a little closer look at the male testis. We get a good picture of it here in a second. There we go. So here's a cross section through the testis. So we've cut through the tunica albuginea, and then these are the seminiferous tubules, which I said you have dozens of meters, I think well over 100 meters of seminiferous tubules in every testis. And so this is a single lobule here, surrounded by the septa. And there are the seminiferous tubules leading into this network of collecting ductules. And the collecting ductules lead to these things that are called efferent ductules, which then lead into the head of the epididymis. Where the seminiferous tubules lead into the efferent ductules, that's an area which is called the rete testis. And really, it's just an area where all the seminiferous tubules feed into the ductules that go to the epididymis. You can see that on some of the slides that we have in the human testis slide. Then we ship those immature spermatids, which are on their way to becoming spermatozoa now, into the head of the epididymis, and then they pass through the epididymis over that 40-day period until they get down to the tail of the epididymis where they become capacitated, and then they leave the tail of the epididymis during emission, travel up to the vas deferens to the ejaculatory duct. And as I mentioned before, the scrotal sac isn't really shown here, but once you come in through the scrotal sac and you get through the cremaster muscle, then you encounter these two layers, which are the tunica vaginalis layers. There's a parietal and a visceral layer, and then you're on the tunica albuginea of the testis itself. And as I mentioned, the tunica vaginalis is actually derived from the parietal peritoneum. When male babies are forming in utero during the late fetal periods, the testes at that time are actually up in the abdomen, and they descend down into the scrotal sac only a week or two before birth, and sometimes they fail to descend even at birth. When they descend down into the scrotal sac, they have to pass through the inguinal canal, and they're pulled by a structure called the gubernaculum, and I think towards the end of the PowerPoint presentation I have a picture that shows that. So that's called descent of the testes into the scrotum. When they do that, they pull with them some of the layers of the parietal peritoneum, and that becomes the tunica vaginalis. The function of the tunica vaginalis, being a serous membrane, is to leave a little fluid-filled cavity in here to allow the testis to rotate within the scrotal sac without damage. So here's a cutaway of a dissected testis, and you can see there's the scrotum. There you can see the tunica vaginalis extending out a little bit right here, and there's the parietal and the visceral layers, and then here is the tunica albuginea of the testis. Here's the epididymis with the head, body, and tail, and then there is the vas deferens picking up here and going up into the spermatocord. And here you can see some of the structures, some fat, and the pampiniform plexus are these things here. Now here's a cut of a histology section of a seminiferous tubule, and our slides in class look an awful lot like this, maybe even a little bit nicer than these slides. So here's one tubule that they're showing with a bracket. I won't draw that because they already have it nicely bracketed for you. The outside of the tubule is lined by what's called a myeloepithelial cell. It actually is a special type of epithelium that has a little bit of muscle fiber in it. That's what they're calling myeloid cells right here. That makes up the boundary of the tubule. Once you come inside the tubule, we're going to have a lumen in here. And in the tubule lumen is where we're going to collect the spermatids. And we can see some of those little guys right here. Those are the spermatids. And some more right there. They just look like thin little, almost like dashes or commas. So these are spermatids, and they haven't matured yet. Remember, these are going to go off and find their way to the epididymis where they'll mature into spermatozoa. Right. Well, before we get to here, we got to start back here. Right. And some of these cells, namely cells like, oh gosh, let's find some here. These guys, okay. These are cells that are going to divide by mitosis or meiosis. And if they divide by mitosis, they'll replenish themselves to keep a constant supply of cells that will eventually give rise to spermatids. So the cells that I checked there, those are called, I don't see it labeled here. Those are called spermatogonia. Well, they call them spermatogenic cells in tubule. Okay, I see it here. This one right here is what I'm talking about right now. And I'll just write the term in here. Oops. Oh boy, I'm not doing a very good job. Spermatogonia. I need a stylus or something instead of using the mouse. All right, spermatogonia. And the spermatogonia cells are, I don't know if you've ever seen this term before, 2N, which stands for diploid. And a diploid cell is a cell that has 46 chromosomes. All right. And so our diploid spermatogonia can divide by two fates. One, they'll divide and give more spermatogonia, and that's if they divide by mitosis. So they can constantly regenerate their supply. If prompted by some of the other cells in the seminiferous tubules, they'll divide by meiosis. When they divide by meiosis, that's when they make this journey. So we have two fates. This guy can divide and give more of itself, and that's by mitosis. So let's put a 1 there. That's mitosis. Or they can divide by meiosis and generate the spermatids. And we'll talk about how that process works and how it's regulated in just a bit. So those are the spermatogonia. Once they start dividing by meiosis, they get called spermatocytes. In the first round of meiosis, they're called primary spermatocytes. Second round of meiosis, they're called secondary spermatocytes. And then they become spermatids. So it's spermatogonia, spermatocyte, primary, spermatocyte, secondary, spermatid is the flow as we go through meiosis. And then the spermatids can eventually mature into spermatozoa later on. So let's talk about one other type of cell we find in here. This big honking guy right here. All right. That's called a Sertoli cell. There's another one right there. Sertoli cell. And this guy unfortunately has 3 different names. Sertoli cell, which I think is kind of my favorite name. It's a Sertoli cell. It's also called a sustenocyte or a nurse cell. So sustenocyte, Sertoli cell, or nurse cell. And these guys, they don't divide. They are what prompt the spermatogonia to become spermatids. When Sertoli cells receive testosterone from outside the tubule, from an interstitial cell, the Sertoli cells then produce androgens and cytokines that prompt the spermatocytes to divide. So really, their job is to drive spermatogenesis. Now if we move, well, and also what they do, and it's hard to see here, but the lateral borders of the Sertoli cells stretch out and they form a barrier along here. It goes all the way around. And I'm not trying to be precise with it, but it goes all the way around. And that barrier that they form is called the blood-testis barrier. Because once we go through meiosis, the spermatids that are produced have a slightly different antigenic makeup than the tubule cells, and your immune system would actually attack them. So the blood-testis barrier produced by the Sertoli cells prevents antibodies from crossing through there and attacking in what's called the adluminal compartment. This area here is called the adluminal compartment, as opposed to the basal compartment. So the blood-testis barrier prevents antibodies from penetrating into the adluminal compartment and damaging the forming spermatids. So the nurse cells, they have 2 important roles. They produce the blood-testis barrier, and they prompt spermatogenesis. If we move outside of the tubule, we encounter some cells. Here we go. There's a couple right there, called interstitial cells. And the interstitial cells are also called Leydig cells, and I won't write that in there, but it's Leydig, Leydig cells. And Leydig cells are the ones that produce testosterone. All right, so now that we've talked about kind of the structure of the seminiferous tubules and where spermatogenesis is taking place, well, let's mop up some of the other structural features that we need to talk about in the male reproductive system. We threw in a slide here talking about one of the diseases that males can get having to do with the testis, which is testicular cancer. most common cancer that men get. Generally speaking, it's asymptomatic until the tumor mass grows large enough to impede sexual performance or semen flow. Usually, classic clinical sign is, like it says here, a painless solid mass in the testis. And if diagnosed early enough before it metastasizes, it's pretty easy to cure by surgical intervention and resection of the tumor. Now here's a funny word, cryptorchidism. Cryptorchidism is fancy speak for undescended testes. So I mentioned earlier how the testes have to travel from a position in the abdomen down through the inguinal canal into the scrotal sac, and they do this just prior to birth. If they fail to do that, that's called an undescended testis, and like I said, the clinical term for that is cryptorchidism. Even if that resolves itself spontaneously in the weeks after birth, which sometimes the testes do manage to, they're just a little late to descend, they manage to descend, and then that's no longer a problem for the testicular function. But even if that is delayed, that's still a risk factor. For some reason, having cryptorchidism, either surgically fixed, undiagnosed, or just one that self-resolves, predisposes a male to have a much higher incidence of testicular cancer. So that's something to know in your medical history. Something that we see from the male and the female is this concept of the perineum. So the perineum is an imaginary triangle that goes from the ischial tuberosity of the ischium pretty much through the anus and up to the pubis, and it makes a triangle. So that's called the perineal triangle or the urogenital triangle. And really it's bounded anteriorly by the pubic symphysis and posteriorly by the ischial tuberosities. There's really not a lot that goes on in the male perineum other than the fact that that's the attachment of the base of the penis. In the female, that's where the vaginal opening is. The male external genitalia, we've already talked about some of that. Let's go to a picture and we'll talk a little bit more about it. I mentioned what circumcision was. That's the removal of the prepuce. It says here 60% of newborn boys in the U.S. are circumcised. Really, there's no medical benefit to circumcision. I can think of two instances that you can make a small claim for here, and that is that, as it notes here, in circumcised individuals, there is a reduced risk of HIV transmission in circumcised individuals as opposed to uncircumcised individuals. And that's simply because the prepuce is an epithelial tissue that's easily ruptured and it's highly vascular, and HIV is a blood-borne sexually transmitted disease. The other thing is that the prepuce, because it does cover the glans penis with a thick fold, that you can actually trap organic matter in there, and bacteria like to thrive in that area. So you have at a higher risk of bacterial infections, whether it be a urinary tract infection or an STD like chlamydia or gonorrhea or syphilis. But other than that, it's pretty much just a cultural custom, whether or not somebody wants to be circumcised. So as we mentioned before, the male penis is the copulatory organ. In order for it to be capable of doing the sex act, it must become engorged with blood, or we would call that an erection. And there are these two erectile tissues, the corpora spongiosum and the corpora cavernosum. And so here we're looking at a dorsal view, and right at this level would be the anterior body wall. Well, actually the body wall is here. This is the urogenital diaphragm musculature right there. So the erectile tissues are actually embedded into the abdominal wall. So they go beneath the skin and connect to the connective tissues of the musculoskeletal system. The two paired corpora cavernosa are on the dorsal surface, and they're the main erectile tissues. And then, as we mentioned, the corpora spongiosum is the central part, whose job it is to keep the urethra open. Both of these structures, the corpora spongiosum has a bulb, and the two corpora cavernosa have a tail-like structure called a crus. Those are embedded in connective tissues close to the pubis. and so that actually is the base of the penis and holds it in place. If we look at a cross-section through the penis, we can see the two dorsal corpora cavernosa and the more ventral corpora spongiosum surrounding the urethra. But look here on the dorsal surface, we have some nerve fibers, and we have some superficial veins in the arteries. That's going to be important for how we generate an erection in the penis. I think we talked about the ductwork a little bit already, how the fact that the testis pass the developing sperm into the epididymis, and then the epididymis connects to the ductus deferens, which transitions the sperm to the ejaculatory duct and out the urethra. So some factoids about the epididymis. And I already mentioned the fact that the sperm enter the head, travel through the body, and into the tail. They give you a net length of the epididymis of about 6 meters in length. Now that's obviously the coiled tubules inside the epididymis. The epididymis is barely an inch long in its coiled form. So I mentioned that the sperm enter through the efferent ductules into the head, and they're non-motile and not capable of fertilizing an egg there as they pass through slowly. Here they give you around 20 days. I told you 40 days. They become motile and capable of fertilizing an egg at the end of that. And then during ejaculation, actually just prior to ejaculation, so it's a little bit different than what it says here, during emission, this would be better to write emission here, the epididymis contracts, expelling the sperm to the ductus deferens and up to the ejaculatory duct. The vas deferens then connects the testes to the ejaculatory duct, and they give you an overall length here of 45 centimeters. And it passes through the inguinal canal. This, by the way, is what predisposes males to developing inguinal hernias. The fact that we have this sort of fibrous tube that passes from the abdomen out to the scrotal sac, and that's called the inguinal canal. And there's a superficial and a deep inguinal ring, which are the openings or the hiatuses that the spermatocord has to pass through. It's fairly easy for that to rupture, and we can have material from the abdominal cavity actually herniating out through the inguinal canal, and that's called a inguinal hernia. And pretty much only males get that. It's not impossible for a female to develop one, but females clearly don't have the inguinal canal, so they're much less likely to have that form. Wouldn't worry about the ampulla, just know that the vas deferens, as it passes posterior to the seminal vesicle, becomes the ejaculatory duct. And the vas deferens is a smooth muscle-walled structure, so that helps propel the sperm. Now this is an interesting term that you should know, a vasectomy. A vasectomy means to resect or cut the vas deferens, and it's usually done just shortly after it exits the epididymis. So you cut a length of an inch or so of it, and you fold it back on itself a few times, and you burn it, and you staple it, and hopefully it scars in nicely and no longer conducts sperm from the epididymis to the ejaculatory duct, and that effectively sterilizes a male. Obviously you have to do it bilaterally, you have to do both sides, and when males have a vasectomy, one of the problems is that after they have the surgery, they frequently don't go for their follow-up visit, where you have to give a sperm sample that has to be checked microscopically to verify that there are no active motile sperm. Some people are just good healers, and so even though they brutally cauterize and ligate the vasectomy, the vas deferens, some people actually manage to heal, and that regrows, and then they conduct sperm up to the ejaculatory duct, and when they have a sex act with their partner, frequently a pregnancy will result, and people are surprised by that. So that happens one of two ways. Either the person heals, and then the surgery was ineffective because there was unusually good healing, or sometimes the surgeon cuts the wrong thing. And I know that sounds like it should be simple, but when you actually dissect this out in a cadaver or in a patient, you'll see that the vasectomy looks an awful lot like a blood vessel and a vein, and so it's relatively easy to cut the wrong thing. So we know the urethra is the urine conducting pathway that goes from the urinary bladder out through the glans penis in the male. And it has three parts that I pointed out to earlier: the prostatic urethra passing through the prostate, the membranous urethra passing through the urogenital diaphragm, and the spongy urethra surrounded by the corpora spongiosum in the glans penis. So just make sure you're able to identify those three parts of the urethra in the models. And so here they're showing it for you again. This is the prostatic urethra. The membranous urethra is just the part that goes through the urogenital diaphragm, and then the rest of that would be the spongy urethra. All right, onto the male accessory glands. What exactly do these three glands do? I'm glad you asked. Okay. The seminal glands, they make the bulk of the seminal, or the bulk of the semen. Their fluid is called seminal fluid. Here they give you a number of about 70%. I've seen numbers of 60 to 65%, but the bulk of the ejaculate volume comes from the seminal vesicles. Mainly, it contains fructose and citric acid, which are carbohydrate sources for the sperm. That's food for the sperm to nourish them on their trip through the female reproductive tract. They contain coagulating enzymes like thrombin, but this is actually vesiculase. And they contain some cytokines called prostaglandins, which will stimulate smooth muscle contraction in the female. There's a yellow pigment contained in seminal fluid that fluoresces with UV light. This is used, you can see this in shows like CSI and Criminal Minds. When they're looking for the contamination of body fluids, they'll use a UV light and they'll spray the sample with fluorescein. And if it binds to these pigments, it'll light up. So you can detect whether or not there's been sex acts at a crime scene. And so we know that where the vas deferens joins the seminal vesicle, that becomes the ejaculatory duct at that point. The prostate, which is just below the urinary bladder, like I said, that's a fibromuscular structure, so it has smooth muscle in it, and it will contract during ejaculation to help propel the semen out of the ejaculatory duct. Prostatic secretions are a milky opaque fluid, slightly acidic, contains citrate and enzymes that are involved in clotting. It contains actually clotting factors and a whole host of enzymes that have jobs in stimulating the sperm to swim, actually, to propagate motility. And then an enzyme in there called, well, it's not really an enzyme, it's a protein called prostate-specific antigen, PSA. PSA doesn't have a particularly remarkable biological function, but it is a marker that can be used to assess prostate health, and I'll talk a little bit about that in a minute. I mentioned that some of the enzymes that are in here are involved in activation of sperm and stimulating them to swim. And prostatic fluid probably makes up about 20% of the ejaculate volume. So this idea of PSA, I think we have a slide that talks about that. Yeah, we'll get to that in a second. So I'll hold on to that for the next slide. Some prostate disorders. Well, prostatitis. Prostatitis is just inflammation of the prostate, and pretty much every male is going to deal with prostatitis to one degree or another as we age. There's acute prostatitis and there's chronic prostatitis. Acute is a flare-up that can include the urethra and actually prevent you from urinating, and that's really the acute danger. If you can't urinate, then you can get toxicity in the blood as a result of backup of the urine into the kidneys, and it can cause kidney malfunction and failure. So that would usually have to be cured by putting in a catheter and draining the bladder. Chronic prostatitis, that may or may not involve acute flare-ups, including urination. Chronic prostatitis is probably most annoying in the fact that it can just simply cause difficulty in urination for males, a weak stream, and it can also cause fertility issues as the prostate is involved in some of the reactions that create an erection. Like I mentioned, the prostate in addition to becoming inflamed in most men as we age on occasion, will also grow. It'll enlarge. This is a condition called BPH, or benign prostatic hyperplasia, and again, all males will have this condition to one degree or another as they age. As a result of the hyperplasia, it puts a little pressure on the urethra, makes it harder for males to urinate. It may affect sexual performance. What causes it could be dietary, could be infection, it could just simply be genetics. Here they list several things. These are ways of treating it, actually. A lot has been made out of diet. There are some things that seem to discourage benign prostatic hyperplasia, like saw palmetto. I don't know how effective those are. If you do have a hyperplasia condition, it can be treated by basically chemotherapy, chemicals aimed at decreasing cellular division. So that would be microwaves, radiation. Or you could have it surgically resected, but that's going to cause incontinence, as the urinary sphincters are located in the body of the prostate. So if you remove that, you're going to lose the ability to control the prostate, to control the sphincters, which control emptying of the bladder. Prostate cancer for males, obviously only males, is a most secondary cause of death from cancers in the United States. This is something that clinicians will track: PSA levels, prostate-specific antigen. This protein that is a marker of prostatic health can appear in the blood, and you will always be in the blood to one level or another. If there are acute elevations of PSA that may indicate problems with the prostate and would be cause for further screening and examination. Elevated PSA levels by themselves don't mean anything. I've read several articles and listened to some talks on this, where really, if you establish with a clinician and they check your PSA levels, which are going to be done in males over 40 years of age, they'll look for changes. So if you come in at 40 and you come in again at 42 for a checkup and your PSA levels remain unchanged, even if they are what would be considered high, normal, or elevated, if they remain unchanged, it's probably not going to be cause for concern. But if they see a rapid escalation in PSA levels, that may indicate something has changed in the condition of the prostate, and that may lend itself to hyperplasia and cancer development. The third of the glands is the Cowper's gland. I mentioned this before, that this one actually produces its thin, slightly milky solution. It says here clear, but it's just a little milky. Just prior to ejaculation, and its main job seems to be, as it says here, lubricate the penis, but produce an alkaline secretion that neutralizes the acidic urine in the urethra, so it doesn't kill the sperm on their way out. This would be the pre-ejaculate. So when a male is about to have a forceful ejaculation, this material leaks from the penis and is an indication of imminent ejaculation. So semen consists primarily of the accessory gland secretions, like we said, mostly seminal fluid, and then second most prostatic fluid, and a little bit of bulbourethral fluid. The testes only contribute maybe 0.5 ml or so to that total ejaculate volume. So here they give you an ejaculate volume, an average ejaculate volume of about 2 to 5 ml. That includes the semen and the that includes the sperm and the accessory gland secretions. In the ejaculate volume you have here, they give you kind of a low number. They give you 20 to 150 million. I've read a more typical number here of estimating this about 450 million sperm per ejaculate, about 450 million. So that's a little low. If this number is under 200,000, you're considered functionally sterile, and we'll talk about that. 200,000 sperm seem like an awful lot, but what we'll discuss is that once these sperm get delivered to the vaginal environment, they don't live long, and the vaginal environment is very, very harmful to the sperm, and so 200,000 most of them will die, and they won't be able to survive long enough to make their way up into the female reproductive tract where they can fertilize an egg. So you can have what's called functional sterility, and that's a sperm count below 200,000 per ejaculate. Okay, so we mentioned, and this is kind of redundant, it goes back over what the function of the semen is. It nourishes the sperm, that's the fructose and the citrate, so that the sperm are able to do cellular respiration and generate energy. They contain cytokines that stimulate sperm activation and sperm motility, and they neutralize the acidic environment in the female vagina. They have a clotting reaction that helps hold that mass together in the vaginal environment. They have prostaglandins that stimulate smooth muscle contraction in the female reproductive tract. And as it says here, that smooth muscle contraction can be considered a type of peristalsis. So the vagina pulses with constrictions, and so does the cervix, which is the opening of the uterus, and the uterus. And that contraction seems to be, at least among other things, a signal that shows the sperm which way to swim. So they know to swim upstream. And it may actually, almost in a swallowing-like manner, mobilize the mass of sperm through the vaginal canal and up into the uterus. There are some hormones in the semen. One of them listed here is relaxin. Relaxin helps dilate the cervix to make the sperm have an easier time entering into the cervix. Okay, I think that's probably all I'd want to mention about that. I wouldn't worry about the other things in the list. So for a male, in order for a male to be able to deliver the sperm to the female reproductive tract, they're going to have an erection in the copulatory organ. The way that's achieved in a male is to go ahead and dilate the testicular, well, not the testicular, the penile arteries, and constrict the penile veins. And that is done by a parasympathetic, usually a sacral response from the parasympathetic nervous system, where the result of our release of acetylcholine causes nitric oxide to be released. And as we remember from our previous lectures, nitric oxide is a powerful vasodilator, and it relaxes because it relaxes the smooth muscle. So the arterioles dilate, the corpora cavernosa, and to an extent the spongiosum becomes engorged with blood, compresses the penile veins, and prevents the drainage, and so that's why the erectile tissues become engorged. And that causes an erection. There's really nothing on this slide I want you to worry about. So an ejaculation is simply the propulsion of the semen into the female reproductive tract from the male reproductive tract. So while getting an erection requires a parasympathetic reflex, ejaculation is a sympathetic spinal reflex. So this is a situation where both halves of the autonomic nervous system are involved. So when the sympathetic stimulation occurs, we have a few things that are interesting to note that occur. The urinary sphincters in the bladder constrict, so that when you have ejaculation, you don't have urine getting into the ejaculate volume. The base of the different glands, the prostate and the Cowper's gland, contract, and they propel the semen from the ejaculatory duct into the urethra. And I don't know who timed it, but apparently ejaculation proceeds at about 11 miles per hour, if you want an interesting factoid. Well, the all-time highest grossing drug ever invented is this guy right here, Viagra. In males that have erectile dysfunction, either they can't get an erection or the erections don't last very long. There's a variety of reasons that may be. It could be neurological, stress, depression, things of that nature will actually affect the autonomic nervous system and maybe prevent the reaction that winds up getting an erection. Or there may actually be a mechanical issue with the penis and the blood flow. There may be constriction of the penile arteries, damage in the penile veins, in particular with the valves. If they fail to retain the blood, then you won't be able to cause the blood to back up into the erectile tissues. But this release of the nitric oxide is what we want to focus on here. So let's say our parasympathetic nervous system is just not giving us the boost we need to get enough nitric oxide released to cause an erection. That's where drugs like Cialis and Viagra come in. They are synergists of the parasympathetic nervous system for these receptors, and they'll actually increase the release of nitric oxide or the stimulating of the nitric oxide receptors and cause localized vasodilation. In an interesting little side story, Viagra was being researched as a blood pressure medication and is actually related to the compounds used to treat hair loss. And one of the theories about what causes male hair loss is a constriction of the blood vessels that lead to the bulbs of the hair follicles. And so like Rogaine causes vasodilation in those blood vessels and increases hair growth. And I believe that is what Viagra was being researched for when they noticed a rather interesting side effect, and hence was born, like I said, the highest grossing drug ever produced. So now we're going to get into this idea of spermatogenesis, which I've mentioned before. Within the testes, we're going to go ahead and generate spermatids, which will become the spermatozoa. They're produced in the seminiferous tubules. And I mentioned earlier that most of our body cells, called somatic body cells, have 46 chromosomes, 2 pairs of 23. Each member of that pair is called a homologous chromosome. So again, we have 46 chromosomes in all of our somatic cells. That is called the diploid number, or 2n. These 46 chromosomes come in 23 pairs. Not 20. Well, yeah, sure. That's fine to say that. 23 pairs. And each member of that pair is called a homologous chromosome. So they're numbered 1 through 23. So you have 2 number 1s, 2 number 2s, 2 number 3s. Roughly, those numbers correspond to the sizes. Number 1 is the largest, and all the way down to 23, which is actually the smallest. Well, 23 is not the smallest. 22 would be the smallest. Pair 23 are the sex chromosomes, which, if it's a female, if it's a female, are 2 X chromosomes, which are actually quite large. And if it's a male, it's an X and a Y, which is actually a non-homologous pair. But that's the only exception to that rule. Gametes are unique. Remember, those are the sex cells, ovum or sperm. They're unique in that they only have 23 chromosomes. And it can't just be any 23 chromosomes. It can't be two number 1s and 2 number 2s and, no 4s and no 3s, but, it has to be one full set. So it's 1 through 23, you have to have one set. And that one full set is called a haploid number, and it's given by the abbreviation N. So as it says here, when we make our one set, it's only one member of each homologous pair. All right, and this is where I'm going to stop for tonight. What we're going to get into now is a special type of cell division that causes the generation of gametes called meiosis. That's how you say this word up here, meiosis. And we have a board in lab, that black board with all the little circular cutouts. And I think that tracks 2 pairs of chromosomes through meiosis. And when I come back, we will talk more about meiosis. Thanks.